Hello, this is the Standing Committee on Health and Social Development. Today is Wednesday, January 27th. This is the 1:30 meeting. Could I get a motion to adopt the agenda? Okay, Charlottetown is doing that, and I want to welcome our members today, Zach Bell, Heath McDonald, Carla Bernard is sitting in for Hannah Bell, Corey Deagle is sitting in for Brad Trivers, Tricia Altaz, and Ola Hammerlin is joining us, and potentially Michelle Beaton as well. So today we're going to get a briefing on the implementation of safe consumption sites, and I'll pass it over to our guests to introduce themselves, and they can continue on with the presentation, and then we'll just maybe ask questions later. So we have an hour for this time. Okay. Thank you very much. Go over to our guests.
My name is Dr. Brittany Jakubiak, and I'm the Executive Director at Piers Alliance.
And my name is Angele DesRoches. I'm the Program Coordinator with Piers Alliance. Thank you. Thank you for having us.
So in terms, just a logistical question, just say slide when we're ready for the slide to change.
Yeah.
Oh, you've got it. Okay.
Yeah, we could develop
the wall's
signal
interesting here.
Yeah.
All right. So we just want to thank everyone for inviting Piers Alliance into the Legislative Assembly to give this briefing on supervised consumption services and harm reduction. It's a really important aspect of the work that we do in Prince Edward Island, and we're very thankful to be in this space and able to discuss some of the things that we're seeing and the concerns and things that are pertinent to all islanders, in fact. So just thank you very much for the introduction and welcome here. So Piers Alliance, for those of you who might not know about us, as well as we hope you know us, we're a community-based organization and we're a registered charity located here in Charlottetown, but we do provide services and programs across the island, not just only in Charlottetown. And we're an organization committed to fostering diversity, inclusion, and health in our island communities. We focus on sexual health promotion and harm reduction within the context of substance use, and we work at the local level to address issues that impact the health and well-being of all island residents. Piers Alliance is committed to providing strength-based, community-driven initiatives that promote resiliency, connection, and inclusion. So what is harm reduction? Harm reduction can be understood as any activity, intervention, or policy that aims to reduce the negative consequences associated with drug use without requiring abstinence or the stoppage of use to be the primary goal. Harm reduction is also a movement for social justice in that it acknowledges the structural inequities that contribute to drug-related harms. Because harm reduction operates from a community needs approach, there is no universal definition or formula for implementing harm reduction in our work. The defining features of harm reduction are the focus on prevention of harm rather than on the prevention of drug use itself, and the centering of people who actively consume substances. This approach recognizes that people who are unable or unwilling to abstain from drug use can still make positive choices and engage in personal development. Harm reduction, at its core, believes in meeting people where they're at and supporting personal priority setting. For example, someone's priority might be housing or having access to their children. Harm reduction is all about maximizing options and opportunities, while recognizing that people who consume illicit substances benefit from access to a range of services and approaches. There's no one prevention method, service, or treatment that works reliably for everyone who experiences a substance use disorder. Harm reduction is also evidence-based, and we will be discussing the evidence around harm reduction in today's presentation. The foundational principles of harm reduction are as follows. Harm reduction is not aspirational, but it's pragmatic. Harm reduction accepts that people have been using psychoactive and mood-altering substances for non-medical purposes since the very beginning of time. It understands that substance use is complex, it's multifaceted, and that it encompasses a spectrum of experiences ranging from benign to positive to harmful. Another principle is rooted in treating people who use drugs and those who experience substance use disorders with compassion and dignity, and this is integral to harm reduction. Harm reduction calls for a range of non-judgmental, non-coercive services explicitly for people who consume illicit substances. Harm reduction recognizes that social inequity, which can be seen through poverty, racism, trauma, violence, and marginalization, increases a person's vulnerability to drug-related harms while decreasing opportunities for effectively dealing with those harms. Another principle is nothing about us without us, and this is a slogan in harm reduction, but empowerment is the underlying principle. People should have a say in decisions that impact them. Engaging people who use drugs is viewed as fundamental to well-designed, well-delivered harm reduction programming because people with lived experiences know things that you cannot learn from a book. Harm reduction does not try to minimize the harms associated with illicit substance use, it tries to address them. Harm reduction recognizes that with information and access to resources, people unable and unwilling to abstain from drug use can still make positive choices to protect their health of their family, and the health of their communities. The priority for harm reduction interventions, like safer consumption services, for example, is to decrease the negative outcomes associated with drug use rather than focusing on drug use and decreasing that itself.
Getting into what are safer consumption services, this refers broadly to any site where community members are able to consume pre-obtained psychoactive substances under the observation of someone willing to step in and intervene if there's an overdose. People who consume illicit substances have long used observed consumption or spotting as a harm reduction strategy, long before sanctioned supervised consumption sites were available. Folks who consume substances were running their own spaces and saving lives in the face of government inaction and criminalization. In Vancouver, peer networks and harm reduction advocates were successfully operating formalized but unsanctioned safer consumption services as early as 1995, and of course that was in the context of the first overdose crisis and HIV/AIDS crisis. More recently, we're in an overdose crisis again. We have toxic street supply and experiencing a pandemic. So we did notice unsanctioned peer-to-peer spotting initiatives were developed to help folks deal with COVID. Some of the more innovative ideas were peer-to-peer spotting happening over Zoom calls, for example. When we look at the movement towards sanctioned supervised consumption services, we look towards supervised injection facilities as kind of the first model that was introduced. So these services are specifically concerned with the harms associated with injection drug use. And these sorts of programs were integrated into some low barrier medical clinics in the late 90s, early 2000s. By 2003, after a lot of community-based effort, Insight, Canada's first legally sanctioned standalone safer injection facility, was opened in Vancouver. Since that time, several other cities in Canada have opened supervised consumption sites with an exemption from the Controlled Drugs and Substances Act issued by Health Canada. Given the emergence of fentanyl and the rise in overdose deaths across the country, supervised consumption sites often include more than one method of consumption. So depending on the site model, Health Canada will approve supervised injection, inhalation or smoking, oral consumption or swallowing, and intranasal consumption or snorting. Overdose prevention sites are also popping up across the country. These sites are conceptualized as more bare bones and short term when we compare them to fixed supervised consumption facilities. And Health Canada has proactively issued class exemptions under the Controlled Drugs and Substances Act to all provinces and territories to establish temporary overdose prevention sites, which are formally known as urgent public health needs sites. So at present time, there is no legal barrier in terms of introducing these services locally. So to get into a little bit more detail around supervised consumption facilities, these are conceptualized as long-term harm reduction service hubs that address the health and wellness needs of people who actively consume illicit substances. So in addition to supervised or observed consumption, folks are also able to access sterile supplies, things like drug checking services, point of care testing, access to HIV treatment, as well as hepatitis C treatment, wound care, and mental health supports would just be a few. Referrals to wraparound services and supports external to the site are also available through these more formalized models. So these services are often able to facilitate more soft referrals to housing programs, employment programs, and treatment facilities. Procedurally establishing a safe supervised consumption site is still pretty laborious and time-consuming, and it can take several years to get approval. The process, the application process for that exemption, it requires information about the site's policies and procedures. It requires things like a floor plan, information about personnel and local context, and a sustainable financial plan. Applications also require proof of extensive community consultation, which can be traumatic for community members, which the site is actually intended to serve. Health professionals are often utilized in the delivery of services at fixed supervised consumption sites, which can add to resource requirements for the delivery of those services. So these sites are, again, typically intentionally built to create service flow and meet the needs of marginalized populations who require access to low barrier services. So often you'll see things like an intake or a pre-consumption area, observed consumption happening in another space, and then a third space where folks would be able to post-consumption area for additional monitoring and engagement. So we can compare that to overdose prevention sites or urgent public health needs sites, again, as they're more formally known. So this is another legal pathway to providing supervised consumption services in Canada. So these sites are conceptualized as short-term services that can be established quickly to meet an immediate community need. Overdose prevention sites can be set up within existing services like shelters or needle distribution programs, for example. In other provinces, they've been set up in tents, trailers, and other temporary locations. Because overdose prevention sites are not required to provide the same level of service, and it's not the same lengthy application process, they can be established relatively easily. Overdose prevention sites lack some of the formal infrastructure that I was talking about in terms of supervised consumption sites. So if we look at probably the closest example would be Refix in Halifax. They currently operate with 3 consumption booths, 2 staff, access to naloxone, and a defibrillator and a phone. So pretty bare bones when we compare that to a facility like Insight, where they would have things like medical practitioners, a clinic space, oxygen monitors, access to oxygen tanks, blood pressure machines. Insight also has a second program on the second level called Onsite, which is a detox and treatment facility as well as a housing program. So you can see the difference in terms of infrastructure. For overdose prevention sites, staff members do not directly assist in consumption or handle any drugs brought in by clients. They're there to present and provide access to sterile equipment, answer questions on safer use practices, administer first aid if needed, and monitor for overdose. And as was mentioned, Health Canada has proactively issued these exemptions to all provinces and territories so that health authorities interested in offering the services don't encounter barriers when trying to do so. The other difference with overdose prevention sites is that they often engage folks with lived experience in the actual delivery of the service, which has been found to make them actually more low barrier and accessible for community members who often find that environment more appealing than a more medicalized service. So there's been extensive amount of evaluation and research done on various models associated with safer consumption in both Canada and internationally. And we can see that what the evidence suggests is that supervised consumption services are very effective in saving lives, connecting people to other health and social services, and improving health and wellness outcomes with a significantly marginalized population of folks. So supervised consumption services reduce the risk of accidental overdose because folks are not rushing or using alone. There has never been a fatal overdose in any supervised consumption facility in Canada, never, not one. And I haven't explored all of the international evidence, but what I've read thus far would suggest there has never been a fatal overdose at any supervised consumption facility. Because clients are provided with sterile, safer use equipment, safer consumption services also reduce the risk of the spread of transmissible infections like HIV and hepatitis C. People who engage with safer consumption services regularly are also more likely to change their consumption behaviors in healthy ways, such as using alcohol swabs or sterile filters, which prevent infections. Clients of safer consumption services are also more likely to engage with other services through formal referral processes and informal information sharing with other service users. In areas with high public consumption, safer consumption sites reduce the amount of use and waste found in public spaces. Staff at safer consumption sites, as well as overdose prevention sites, are often involved in community cleanup efforts, so picking up debris and gear in the neighborhoods that they're located in. Studies have also noted that clients of safer consumption services are more likely to seek treatment for a substance use disorder, which is also a significant finding. And there have been numerous studies that show that safer consumption sites are cost effective when weighed against the cost of overdose and other drug-related harms, such as abscesses and infections, hepatitis C and HIV treatment, emergency medical services, and loss of life and productivity. So safer consumption services are offered within a socio-political context that has resulted in a lot of myths being generated around this type of service. So just want to take a few minutes to address some of those. Safer consumption services do not promote or encourage illicit substances. They are specifically targeted to meet the needs of folks who are already consuming substances. There's no evidence that safer consumption sites increase the amount of drug use occurring in communities, and as has been stated, interaction with harm reduction services like supervised consumption sites increase the likelihood that a person will seek treatment for substance use disorder. Safer consumption sites are also not Band-Aids, they're life-saving services that should be offered alongside treatment and prevention. Safer consumption services exist because treatment and abstaining from substance use are not always realistic options for everyone. And if we're willing to accept that relapse is a part of recovery, then ethically treatment cannot be the only option that we're providing folks in the context of a pandemic, an overdose crisis, and an increasingly toxic street supply. When we look at the increasing presence of fentanyl, the efforts that have been put in place to help mitigate the COVID-19 virus, the fact that we have very few services specifically targeted to folks who consume substances, that can lead to some pretty awful outcomes. To date, there has been no peer-reviewed research that links safer consumption services to increased crime rates. Insight Clinic has been rigorously evaluated since 2003, and community impacts assessments show a positive effect on the surrounding community. Despite suggestions made in a recent review of supervised consumption sites in Alberta, there is still no credible evidence linking safer consumption services to increased crime. In terms of local need, it's important that we acknowledge that illicit substance use and high-risk methods of consumption are happening in island communities, whether we like it or not. Research estimates suggest that anywhere between 350 and 570 island residents consume substances by injection, and I would suggest that that's probably a low estimate. The presence of fentanyl has increased in the illicit market and is impacting all island residents who consume substances. So since March 2020, 75% of overdose cases have been linked to fentanyl. We can compare that to 2019 when that number was only 20%. The contamination of street supply with fentanyl is particularly concerning well, it's concerning for everybody, but additional risk factors for folks who consume stimulants and who would have almost would have no tolerance for opioids. So it's increasing overdose risk factors for stimulant users when we start to see that toxicity in those types of drugs. Drug use has been identified as the most prevalent risk factor for those who are diagnosed with hepatitis C in Prince Edward Island. 77% of those diagnosed report a history of injection drug use, which is higher than the national average. And the majority of those diagnosed in PEI are between the ages of 20 and 34, which is young. Concerns and complaints around public drug use and discarded equipment and materials also suggest a need for a safer consumption site or safer consumption services provided locally. And people who consume illicit substances in PEI have indicated that safer consumption services would meet a community need, and that's something that our organization has found anecdotally in communications with some of the folks that we're working with, as well as in focus groups that we've run with community members, and most recently in a check-in survey that we did with folks in terms of impacts to the illicit market after COVID or in the face of COVID. So we can do better than that, right? Like, I think that's part of the reason that folks are engaged in this particular conversation right now is the realities of the closure of the covert and the environments that folks, community members, constituents are existing in. We clearly need non-judgmental, non-coercive services explicitly for people who consume illicit substances, and an overdose prevention site would be a big step in the right direction. We would strongly recommend to this committee that they petition the Minister of Health to implement that exemption and initiate the process of introducing overdose prevention services in Charlottetown. Additional recommendations would include working with other government actors, community-based organizations, municipalities, and other stakeholders, providing support to folks who consume illicit substances to find a suitable location for an overdose prevention site. To consult with community members who consume illicit substances to better understand consumption needs, and to ensure appropriate overdose prevention site staffing by mobilizing the resources needed to train and employ people with lived experience to deliver those services. Thanks so much for your time, and we'll be happy to answer any questions that you might have.
Great presentation. Thank you very much.
Thank you.
So we'll just open up for questions. So Trish?
Thank you, Chair, and thank you both so much for this presentation and for being here today. Angele, one of the things you mentioned, toxic street supply, something that we're facing currently. I was wondering if you could elaborate on this a little bit and what some of the changes have been in drug use on Prince Edward Island in recent years, and particularly due to the pandemic.
Yeah, so I think like demonstrating that causal relationship can be difficult, but in terms of what I see and hear, we're noticing an increased presence of fentanyl. So pre-pandemic, folks who were consuming opioids for non-medical purposes did have access to a pharmaceutical supply that seems to have dried up in the context of COVID. So hearing more about things like access to heroin and fentanyl, which wasn't as popular pre-pandemic. Also hearing about a lot of contamination. So purple heroin, for example, which is not heroin, and pink cocaine, which would indicate, again, contamination, and methamphetamine that may look like methamphetamine until you cook it when it turns black, which would also indicate a high degree of contamination. One of the issues that our organization struggles with is that we don't have access to things like drug checking services where we can go get a complete printout of what is contained in those substances. So sometimes when charges are being laid, for example, after a drug seizure, those reports will come out after a law enforcement agency has had products analyzed. Unfortunately, we don't have that information, but anecdotally, we are hearing from community members that supply has changed.
Trish?
Thank you, Chair. And you mentioned that we're now at 75% of overdoses are due to fentanyl, and just what a drastic change that is, and what a serious issue this is on Prince Edward Island. You gave us a kind of a few different models of what an overdose prevention service could look like. And one of the things that you mentioned that I hadn't really heard about before, or wasn't aware of, was the idea of the urgent public health needs sites, and that there's a different sort of reason for implementing those, or a different level of sort of barriers to make that happen, and whatnot. So would that sort of shorter term service be something that would be worth looking into for Charlottetown as an immediate next step?
That would be the recommendation that Piers Alliance would make to this committee.
Trish?
And in other places where they have implemented these urgent public health needs sites, you know, what sort of immediate impacts have they seen? And perhaps where else other than Vancouver are they happening? Are there other places?
Yeah, so Refix in Halifax would be the closest example. And I don't know that it's pretty new. I don't know that they've done like formal evaluation and released a report. Just in conversation with colleagues, I can say that it's making a significant impact on the lives of folks who live in those communities and neighborhoods. From what I understand, it is being utilized by community members. They haven't had overdose experiences, but a lot of positive feedback from community members who are happy that they have a safe place that they can comfortably go and consume and connect with service providers in a way that's comfortable for them. So they are seeing a lot of repeat clients, for example, which would be a great indicator of success. Again, an early indicator of success, but an indicator of success nonetheless.
Trish?
Yeah, thank you, Chair. And you mentioned as well that safe consumption sites or prevention services often involve healthcare professionals also being on site, but that the cost of that is, you know, in many ways you could look at it as being perhaps offset, or the way that it impacts the long-term costs in health for our healthcare system, where we are preventing overdose and we are preventing infection and whatnot. So I guess, is that something that I don't know if there are any numbers on that, or any more information perhaps from the site in Vancouver that we could share, or that you could share with the committee as well, if not today, but send us some of those resources, because it would be really great to get a sense of exactly what that cost offset would be, because it would seem quite significant in making those longer term decisions in terms of what's good for our healthcare system and what's good for Islanders who are in need of these services, right? So.
Yeah, I guess what I can say to that is that what I've noticed just through informal scan of what's happening across the country is that there are a lot of organizations who have a lot of infrastructure already, who are able to offer short-term overdose prevention sites and roll them out with the same infrastructure and supports as those more fixed supervised consumption sites. And so what that tells me is that when we look at, for example, the timelines of exemptions from the Controlled Substance Act, the overdose prevention sites provide an exemption for 6 months, but the process for safer consumption sites still have to be repeated annually. And so I think organizations are making the decision that because overdose prevention sites can be rolled out more quickly and aren't as traumatic for the community that they intend to serve through that community consultation piece and lengthy kind of trying to create an environmental readiness, that's kind of the preferred model. That said, because those services have that infrastructure, they are often able to include things like a nurse practitioner who would oversee the overdose prevention site. So different models, but I can absolutely get back to you with more concrete numbers in terms of cost savings.
I know others have questions, so we can move on.
Okay. Carla?
Thank you, Chair. Thank you so much for taking the time and energy to put into this presentation for us. It was really great, and particularly I really liked that you addressed the myths in there. We've gone horribly wrong in understanding drug use and criminalizing drug use, and so this is a great, I guess, first step in that. So one of the questions that on the slide, you had said that Health Canada proactively issued exemptions for all provinces and territories. When was that done?
I believe so it happened twice, if I'm not mistaken. I do have a date. You just might have to be patient with me. I believe the first time was 2017, but I can get back to you with specific dates. I do know that exemption is in place right now until September. But I can get back to you with concrete date in terms of when it was reinstated.
Is that okay? Carla?
Thank you, Chair. I guess I was trying to wrap my head around if it was something that was put in place as a result of the pandemic, but it goes back farther than that. But obviously, that's not something that's permanently put in place. They can kind of take it.
Right, so you need to apply for that exemption every 6 months. And so I think the context of how overdose prevention sites or those urgent public need sites came about was through efforts of local health authorities, primarily in British Columbia, who were facing extreme numbers in terms of overdose cases and needed to ensure that they had enough sites available for folks to consume. And so I think that was really kind of the history of how they came about. And I may misspeak, but I do believe that in face of COVID, federal government realized that this would be a good option for every province and territory to have at their disposal.
Carla?
Thank you, Chair. You had mentioned Charlottetown as a potential site for the supervised consumption site. I'm wondering, is this something that you're seeing in more areas of the province, or have you been kind of specifically focusing more around the Charlottetown area?
Yeah, Piers Alliance is an organization that operates with a provincial mandate, but we are a small community-based organization, and so we do spend a lot of our time in Charlottetown core. Our recommendation for locating these services in Charlottetown is recognition of population demographics, the fact that we see shelter services located here, that we know that in terms of population concentration and folks who would use the site, it seems like a good first step. But absolutely, there are folks all over the island who are experiencing these issues and are at home alone in a bathroom with the door locked, and that's not a great situation for anybody to be in. Another project that Piers Alliance is working hard to get off the ground is an overdose prevention hotline, so folks in those more rural communities could at least call a peer and say, I'm consuming, let's have a chat for a little while, and you'll make sure that I don't nod off and don't wake up. And in the event that the caller became unresponsive, that overdose prevention line coordinator would pick up the phone and dispatch emergency services. We're encountering a few challenges around that in terms of insurance. So that's been the hold up there.
Carla?
Thank you, Chair. I'll ask one more question, then I'll let you go to someone else. I'm just wondering, kind of in your research and in conversations that you've had, excuse me, if someone has an overdose and they're not alone, there's someone with them, is there a fear to call the police or to call for fear of, retaliation or consequences? Even though that's not, I know the federal law prohibits that, but is there still that fear?
Absolutely. I mean, folks are concerned that they're going to get in trouble because we conceptualize drug use as a criminal act. And often, anecdotally, when police arrive at an overdose scene, there is questions as to where the substances came from and things of that nature, which isn't the best environment to encourage community members to be making those calls. So yes, I would say that it is still a concern for community members. Another project that we're working on is more awareness raising around the Good Samaritan Overdose Prevention Act to let folks know that when you are calling 911 in the event of an overdose, the focus is not supposed to be on the illicit nature of substance use. You will not be charged for possession. You will not be charged for probation violations or conditional release violations or parole violations. That said, it doesn't, the act doesn't protect you from everything. So if, police or ambulance arrive at a scene and you have scales, for example, or baggies, for example, which folks may have as a harm reduction strategy to kind of monitor how much they're consuming, that is evidence of potentially distribution or trafficking, right? So there is there are a lot of factors that criminalization bring into an emergency situation that are super unfortunate, and absolutely our community members contend with those before they pick up the phone.
Heath?
Thank you for the presentation. You talked a little bit about partnering with different organizations. Which organizations were you considering partnering with? And I know you mentioned non-for-profits and that, but I guess my question was, is there any relation between Canadian Mental Health and yourselves? Are you doing anything together in that regard? Or is that, no?
We've had informal partnerships with folks at CMHA on different projects. We haven't spoken to them about this one specifically.
I guess, when you're going to government, and I've been in government, the more you have as in the box to share, and this is a very important issue, and I was the one that brought it up in the House, and I'm 100% behind in what you're trying to do. So I guess what I'm trying to do is, sitting on this side, is form an opinion for you to execute what you want to do, and I think it's extremely important. Has the city reached out to you, or the medical society, those types of groups? Have they been in communication with you after that was presented by the Guardian? Has anybody come forward and said, we want to work with you?
No, not formally. We were asked to present to Charlottetown Police Services about Piers Alliance and the folks that we work with, and how to best. The police services asked us, from our perspective, how might they best interact with folks using substances. So we delivered that presentation 2 weeks ago to a selection of city police. And we really focused on, person-centered care, and we talked about the Good Samaritan's Drug Overdose Act and letting EMS take lead, but we've not been approached by the city as of yet about the culvert being sealed in particular.
Heath?
So just something else too, because we've got, the city of Summerside, Montague, obviously, Charlottetown, and drug use is rampant wherever. It doesn't behold where you live. Has there been any thought or process put into mobile clinics?
Yeah, my knowledge of mobile clinics is less extensive. My understanding is that there's only one mobile overdose prevention unit that's been approved by Health Canada. There are concerns and issues with ensuring that the space is equipped for appropriate overdose response. So things like the size of that vehicle, how that vehicle would be staffed, making sure that you can lay somebody down in the back of that vehicle if you need to administer CPR and first aid and naloxone. So some of those more logistical pieces. But I can get back with more information on mobile overdose prevention services, but I'm less aware.
Heath?
So I have one more question. Just the Nova Scotia, the Halifax site, how long did it take roughly to have that up and running, to your knowledge?
It's been a long process. That was a grassroots effort, really led by community members who recognized that this was a service that they needed, and to speak from what I know, they didn't receive a ton of support from them from their local government or health authority. And so they were able to open in a location with some patchwork funding. That initial location was closed. When COVID happened, they were presented with another funding opportunity that would allow them to relaunch, and so they were able to relaunch in another location as Refix just a few months ago. But in terms of getting community ready and trying to assemble resources to launch this, it took them a long time.
We might assume that it would equally take some time in PEI for an overdose prevention site. because it's lots of factors to consider. You know, there is funding, there's public support for it, there's an adequate space that isn't going to be not supported by the community in which the site finds itself being opened in. That's something that we need a lot of folks on board, and partnerships built between Piers Alliance, the government, the city of Charlottetown. There's a lot of pieces at play. We want the neighborhood feeling good about that service. We also want to do consultation with folks who are using substances, right? And we want to know what it is that they need, and so that we can support their vision for the service, and let them take lead as well with our support.
Great. Zach?
Thank you, Chair. Thank you again for the presentations, very insightful. Kind of following along with what Heath was saying, do you have like specific numbers from Refix in Halifax as to, the numbers, first of all, like I think it was 570 islanders approximately, or maybe more, that are using here. Would you have numbers for Halifax as to how many people are using the new?
No, but they're expected to release a report at the conclusion of the pilot stage. Like I mentioned, these exemptions are only provided at 6-month marks, and so I know that's something that they're working on, and certainly when those numbers become available, I can provide them.
And, sorry, Chair. Is there any other sites in Atlantic Canada that might be, like even one of the overdose prevention sites? Or I guess my question along the lines of, and with the population of PEI around 150,000, are there safe consumption sites in areas that would be basically like in a city that might have a population close to the entire province?
Hamilton is currently engaged in efforts to launch an OPS, and Newfoundland is very close, and I think what they're envisioning is a little bit heavy in terms of infrastructure.
Zach?
Thank you, Jay. Thank you.
Corey?
Thanks, Chair, and thank you for your presentation. You had mentioned that you would like our committee to, I guess, one of our recommendations to be to the minister to, what was the, sorry.
To enact the exemption.
Have you spoke to the department or the minister on this at all?
Not on the overdose prevention site. We are partnering with the Department of Health and Wellness on our overdose prevention line project. But I think that after Minister McDonald or Heath McDonald publicly kind of called for some of these services, it's been happening very fast. We've not yet had an opportunity to speak to the Minister of Health.
Corey?
No, I think that's fine, Chair. Thank you.
Okay, perfect. Thank you. Ole?
Thank you, Chair. Even though my district is Brighton, which is mainly a suburban neighborhood, it's a serious problem there too. So I really appreciate your efforts to address this. And I'm, it's nice that there's two options. Obviously, the low-cost, quicker options are the mobile, whatever. But I'm more intrigued, of course, with the bigger and more expensive site where you can treat people, offer them other options than the one they're at. Could you, do you have any idea what the cost is of a site like that?
I don't have any numbers in terms of what Insight's operational costs would be, which I think is probably the most advanced, comprehensive, infrastructure-heavy, supervised consumption site that's operating in Canada. But I could certainly get those numbers to you.
Ole?
So you say in your statement that you're not really, that creating sites doesn't increase criminality, or that makes perfect sense. People get their stuff wherever they get it from, just use it in a safer spot. But obviously, to really get a handle on criminality, you need to do something about the supply as well. Could you talk a little bit about what like the future options would be like for decriminalizing drugs, and where you see it going and where they're taking it in other communities, other countries?
Yeah, and I wish I had a crystal ball. But I guess what I can say is that there's a lot of conversation happening nationally around safe supply initiatives. Using medical prescribers to move folks away from toxic illicit supply to a pharmaceutical grade version of what they're using, and that's not a replacement program, that's geared towards getting someone off of a substance. Safe supply would consider things like the motivations for the person using the program, including the pleasure seeking that often accompanies substance use. So it's not quote unquote a recovery focused program. It's simply about increasing engagement with healthcare and moving somebody off of an illicit street supply to a safer pharmaceutical one.
Well, I certainly hope your efforts will kind of break down the barrier between illegal drug use and sanctified drug use, which is obviously everybody takes drugs, including myself. My blood pressure pill isn't particularly addictive, but I definitely need it. But I don't think there's any particular difference between, say, taking Valium or taking heroin. It's like satisfies a need, and one is prescribed by a doctor and may even be paid for, whereas the other one you commit a criminal act. I hope we can get that divide away. Thanks for your efforts.
Thank you.
Do you want to, Trish?
Thank you, Chair. One of the things I really appreciated in this presentation was highlighting the importance of consulting with those who, who are using drugs and who would be accessing these types of services. One of the, you also had a picture of the culvert that was closed and had mentioned some of the impacts of that. I have a written question right now out to the minister, trying to get some answers as to whether or not those who were living in that culvert and who were using that culvert were actually consulted about it being closed before that happening and offered services and supports. I'm hoping that they were before that happened, but I do not yet know that. What sort of timelines and approach would you recommend in terms of an effective approach to consultation with those who are using illicit drugs and who would be accessing the safe consumption or the urgent needs site services?
I think that's a great opportunity for government to use community partners to reach out to those populations of folks who are harder to reach. And so organizations like Piers Alliance would definitely be well positioned to help with that piece of the work.
Trish?
Yeah, thank you. No, I really appreciate that. One of the another recent development, of course, is the mobile health crisis teams that are soon to be implemented. We're awaiting details on the full implementation. But recently, the Minister of Health went against recommendations to include police as part of those mobile health crisis teams. And I wonder if you might be able to comment on what impact that might have for those who the mobile crisis team might be supporting someone who is, either overdosing or seeking immediate support due to a drug use issue.
Yeah, and so I definitely appreciate that those are tough decisions to make, because we want everyone to feel safe and protected in doing the work that they're doing as well. So we were super excited to hear, we're happy to hear that officers will be at least in plain clothes. I think what we need to remember is that we're often talking about a population who deals with a high degree of surveillance, a high degree of criminalization, and often a difficult relationship with law enforcement. And so those issues are challenging, but hopefully we're able to work together as community partners to continue to promote the health of marginalized folks.
Trish?
Thank you, Chair. Yes, thank you. And would you see police having any role in a safe consumption site?
No. That was a short
clear answer, thank you. All right, I think those, oh wait, one more question, sorry. So we touched on this a little bit, but we've been speaking specifically about Charlottetown and some very good reasons why this would be, Charlottetown would be an appropriate place to host or to have an urgent needs site. What other sorts of harm reduction strategies might we implement beyond the phone line that you're working on, which it's wonderful to hear that's moving forward? Are there other ways that we could approach harm reduction in other areas of the province, and particularly more rural areas?
So I can speak to what Piers Alliance has on the go. We've signed an agreement with Chief Public Health Office to act as a satellite distribution for safer use supplies, utilizing the same materials that Public Health has access to through their needle exchange program. So although we're not able to disseminate things like pipes, which would be an unmet need in community, we are able to disseminate safer use injection kits, and do plan on offering evening hours at Piers Alliance office in a second stage of that, so folks are able to access in the evening. We know that the hours for the publicly managed needle exchange program can be prohibitive for some folks. We've also had some informal conversations with RCMP around what creating a pathway to drug checking services for public health purposes would look like. So that's very, very early days, but would be another example. And a lot of, I would say, development in terms of peer networks, because those are the folks that really have the information and the knowledge that needs to be shared. So engaging peers, folks with lived experience in things like street outreach, supply distribution through personal networks, those are also some of the harm reduction strategies that we're engaged in. Safer use education is also something that we offer, and we've been happy to partner with the Community Outreach Center as kind of a home base for some of those activities.
Another piece would be just more availability of Naloxone and Narcan kits. Folks can get them at needle exchange sites or needle exchange programs. It'd be really great if we had some availability, utilizing the spaces that folks might already be accessing, like pharmacies, where someone could access one of those kits. We also know that the kit itself, with it being in a syringe and that being somewhat complicated for some, currently the province does not offer the nasal spray naloxone, but that could be something that is explored in terms of ease of use. It's much easier to use the nasal spray versus giving someone an injection of Narcan.
Thank you. So have you been in touch with the Pharmacy Association at all about their involvement and what role they might play in supporting this?
No, I have not.
I'm sure they would be very interested to engage in that discussion. So just one last question on this then. Are there any timelines laid out for the expansion of services in rural areas that you just spoke about?
So we are challenged with capacity, right, at Piers Alliance. Through the Overdose Prevention Hotline, we are hoping that additional services will kind of organically grow through that. So a caller may say, I'm in a rural community, I don't have access to safer use equipment. The line operator would have some skills in terms of navigating that conversation, seeing if the person was comfortable providing an address, talking about the safer supplies that were available, offering things like mail out or drop off services. So we're kind of just piece by piece, trying to move little bits and pieces forward. But we recognize that this is a need in every single island community. Unfortunately, with the concentration of services in Charlottetown, what we often see is folks, hitchhiking, driving, walking to Charlottetown in order to access things like shelter services. And that's why we're advocating for the location of an overdose prevention site in Charlottetown core, because we know folks are traveling here for services.
Heath?
This is kind of beyond what you're trying to do now, but I'm just wondering, in the future, have you given any thought to getting into the school system and doing education components in relation to what you're doing here? I think it'd be a really good way not to educate people that have those myths about what you're trying to achieve, because I'll tell you, when your child comes home and tells you something and agrees with it, it makes a parent stand up and say, okay, they know more about this than I do. And I think, MAG Canada done it and so on and so forth through drunk driving. And I think it'd be something that you guys should focus on as well, is because it's not, they're human beings and they need to be treated with dignity, and they're family members, and the families are the ones that, it's a trickle-down effect, and all of a sudden the family breaks up, and you have single parents, and you have mental health issues, and it just goes on and on and on. So I think there's a whole gamut. I think you are being likely hit from every angle, but I can tell you from everybody on this committee, if there's anything that we can do, we'll certainly do it, or if you need us to write letters, I'm sure we'd side with you and try to do whatever you need to do to be accomplished in it. Thanks.
We very much appreciate the support, and I think you're right in that there's a long list of work to be done in this area locally, for sure.
Carla?
Thank you, Chair. And just kind of building off what Heath said, I know that in chatting with you before, you've had struggles with getting into schools for various reasons. And I'm imagining one of those reasons would be a certain level of discomfort with the topic, right, wrong, or indifferent. And also, of course, the capacity that you have as an organization is extremely limited. So in hopes that that work could continue, this would need to be like a multi-stage thing, right? To have this roll out really in an efficient and effective manner, if we're not just kind of doing something to do it, but to do something with an eye to early intervention and prevention and moving forward. So I'm just wondering, I know that you've done the initial consultation, and thank you so much for these documents. I just started to read through them, and I look forward to finish reading them. I'm wondering, based on that and based on what you know, what sort of protections would you say are important to have in place for both users of a service like a safe or a supervised consumption site, for both people who use that site and people who are employed at that site?
For safety considerations? Yeah, so I know things like panic buttons have been explored for a lot of services, just to create a tool in instances where someone may be disruptive with increasing methamphetamine use in our province. Things like drug-induced psychosis are another harm that we're seeing more and more of. I would say that a well-trained peer is well skilled in terms of creating a calm environment to effectively deal with that situation without bringing in some type of punitive response service. But certainly, depending on how much infrastructure is built around these types of services, there can be intentional planning, things like deep desks so that there's a space between folks who are coming in at intake and the staff member behind the counter. For overdose prevention sites, because they typically are delivered through peer networks, often these are folks who are known to each other, and so it is sort of a different dynamic. I guess I'll leave that there.
Great. Perfect. Thank you. Okay.
Thank you, Chair. And of course, important to this service, crucial to this service, is a non-judgmental, trauma-informed philosophy. And so I'm wondering who you would see, in an ideal world, if you were running at full capacity and were able to, I'm wondering who you see kind of taking charge of these sites in an ideal, if you had your way, sort of thing.
That's a loaded question.
Sorry. You don't have to answer if you don't want to.
Well, we know from community members and peers who are engaging in substance use that they do prefer when such services are run by community-based organizations, and in PEI that would be Piers Alliance. We recognize, though, the value of partnerships between organizations like our own, with the local government, with the city, with other organizations, and it's one person can't tackle this alone. And as amazing as we are, we need to build stronger partnerships too, to meet the needs of community members.
I just have a couple questions here. I know we're running out of time. Did the city of Charlottetown consult with your group prior to the filling in of the tunnel? have you talked to any people that would have used that tunnel since it was filled in?
Yeah.
Can you give me some stories? Like, what would happen to somebody that used that as their safe place, and what's happening to them now? Like, where are they?
They've moved to behind buildings, inside, bank, doorways. It's dispersed community members, right? So that's definitely not a safer consumption space, right? Like, let's be real about that. But it is a space that was out of the elements, that often there was more than one person present. And so in some way it was creating an opportunity for observed consumption. Now what you're more likely to see is, someone who's going into a 24-hour gas station or, business and using their bathroom, again, locked in a room alone, or outside, behind a building.
You wake up the next morning, you see the tunnel's been filled in. What's your reaction as an organization?
It's painful, right? You know that it means that for folks who are already struggling and having a really hard time, they're going to be struggling even more, trying to find a new place to be, right? Our response can't just be pushing people away. Where are these people going to go? They're still here. They're just not there.
It's also winter. Right? That decision was made in the worst season of the year to make that such decision. Yeah.
And you talk a lot about harm reduction, and I mean, amazing work. Can you rate our province on harm reduction over the course of the last year? What, out of 10, what would you give our province?
3. And I say that because our conception of harm reduction doesn't match up to what the philosophy of harm reduction is. So we have things like a needle exchange program, which is absolutely fabulous, and some great nurses working there for sure. But it's open between 1 and 3 in the afternoon, 3 days a week, which really doesn't reflect community need. That's an example of a service being built for the service providers rather than the clients. We have things like methadone and Suboxone for folks who are struggling with opioid use, but in terms of having conversations around safe supply, that's kind of where the conversation is here. And so that's why I'm saying a 3. I think we have very, very few services that are specifically, explicitly targeted to folks who are consuming illicit substances and for whatever reason have no interest in stopping.
I think that's a great answer, and I think there's obviously more questions, but I think you've done a great service to Islanders by being here today, and I want to thank you very much for coming in, and it was a pleasure to hear your presentation.
Awesome. Thanks so much for having us, folks. It was great.
Thank you very much. So we'll take a short break, and Chief Paul Smith, I think, is ready to come in and speak, so we'll take a short break. we're back. Moving on with, I guess, 3B of our presentation. So we have Chief Paul Smith here today to talk about the same issue. So I'm going to pass it over to you for maybe a statement, and then we can open it up for questions, and just hopefully you're feeling comfortable. Great.
Thank you, Chair. Good afternoon, everyone, and thank you for the opportunity to come in here today and speak with you. I've prepared some opening comments, and following that, if you've got any questions or anything like that, I'll do my best to see how well we can answer them. But in all likelihood, over the course of your presentations that you've heard, you're probably well versed on the subject of supervised injections or safe injection sites. I would preface my comments by stating that words matter, so as such, I'll refer to them as supervised injection sites versus safe, because I believe that we should recognize that regardless of whether an individual chooses to administer such substances, it's never safe to inject any kind of illicit drug. The points of view on the matter can be as varied as the range of services and help offered in such sites. Those advocating for would contend that the introduction of a site would be a welcome addition in the fight against addiction. On the other hand, opponents of supervised injection sites would likely insist that these sites do little or nothing to deter drug use, are roadblocks in the battle against addiction, and do little to support the recovering addict. Not to mention the idea of location, not in my backyard, that type of sentiment. Depending on your view, some would say these supervised sites can offer clean space for people to bring their own pre-obtained drugs to use in the presence of trained staff to potentially reduce or prevent accidental overdose, and in some instances provide a space where those using the service will not be victimized by others. While this first viewpoint is understandable, as I understand it, when established, these sites can do offer a range of services to individuals. Certainly they provide a supervised environment to monitor individuals to prevent accidental overdoses, and they also provide broader harm reduction strategy going forward. The use of illicit substances has long been an issue around the globe. We have penalties prescribed in law and statutes such as the Controlled Drugs and Substances Act, and as law enforcement agencies, we use these tools available to us to tackle the issue of illicit drugs. But we have long recognized this is an issue that as law enforcement, we can't arrest our way out of it. As individuals, we have to look at the issue from other perspectives. If you look around the room, you see a variety of people, brothers, sisters, parents, partners, co-workers, employers, the list goes on. I'd ask you to think, have you ever heard of a child or a young adult say, when I grow up, I want to be a drug addict? Certainly not. Drug addiction is not a conscious decision, it's an illness that can manifest itself from a variety of causes. Peer pressure, victims of physical and sexual abuse, stress, learned behaviors, social economic factors, poor decision-making, judgment, self-control, and risk behaviors are just a few. When we as a society respond to and care for those persons living with addiction, we should take into consideration the issues that may have led them to become addicted. And when we do, it may become apparent that we should stop making it a priority to shame and criminalize the behavior. Harm reduction strategies are means to reduce the health and social harms associated with addiction and substance abuse, without necessarily requiring individuals to abstain or stop. In these instances, harm reduction approaches could include services and practices that provide choices on how to minimize harms through non-judgmental and non-coercive strategies in order to enhance skills and knowledge to live safer, healthier lives. This is evident in the province's current needle exchange program. Staffed with the appropriately trained personnel, with access to additional resources, these sites can and do provide a broad array of help and assistance, not just to persons they serve, but to the broader community. These include prevention of accidental overdoses and potential overdose-related deaths, harm reduction services like drug checking that allow people to determine what is in their substances and potentially take action to reduce any risk, i.e. fentanyl. With proper needle exchange, reduce the spread of infectious disease such as HIV and hepatitis, reduce public drug consumption. With proper needle exchange, reduce instances of needle discard in public spaces, access to important health and social services that may help address issues of homelessness, mental health, substance use treatment for those who are ready for it, potential for reduced resourcing and costs associated with emergency services hospitalizations. The issue of intravenous drug use can be prevalent, or has been prevalent in Canada for years. To my knowledge, Insight BC was the first supervised injection site in Canada, and it's been in operation since 2003. Information from Insight BC up to 2019 indicated there was 6,440 overdose interventions over the course of their operating period, 1,314 occurring in 2019, and they have no recorded deaths. Harm reduction strategies will continue to be controversial. Some will see them as life-saving, others will see them as enabling. What cannot be ignored is that such strategies can provide a more holistic approach to substance abuse. Regardless of one's viewpoint, there exists a need for honest, open dialogue between police, advocacy groups, and governments on issues like supervised injection sites and other harm reduction strategies. Issues surrounding crime and addiction are inherently linked and are dependent on the collaboration of all sectors. Thank you.
Great, Paul. Thank you very much for that. So we'll just open it up to questions now. We have Trish.
Okay, thank you, Chair, and thank you so much for being here and joining us today and engaging in this discussion. You mentioned about drug checking as a tool or a resource that could be used, and that was mentioned in the previous presentation as well. So could you elaborate a little bit on how you might see that utilized more effectively here in Charlottetown?
If you had such a site, it is possible with drug testing kits to determine what may be the makeup of the substance that an individual may have. So it may show the presence of other agents that some may use to cut down other opioids. Example is the presence of fentanyl. We've seen some fentanyl deaths in PEI this year. In some instances, from what we understand from the information that we've been able to glean, is in some instances people are ordering their product with fentanyl in it. The problem with fentanyl is it's an easily concealed substance. It's very small. A small amount can create a lot of issues, in terms of overdose deaths and that kind of thing.
Trish?
Yeah, thank you, Chair. And I do get a little concerned when we start heading down the path of focusing on this idea that people are ordering, the fentanyl specifically. There may be some people doing that, but respectfully, we do know, of course, that there are many who are consuming fentanyl without knowing they're consuming it, right? So I want to be careful that we don't start, as you mentioned in your presentation, down that blame and shame sort of path that we know does not lead to productive outcomes or actually make a difference for those, I just want to make sure we're not sort of sweeping over the issue here of making sure that we are looking at harm reduction and the benefits of that. So you also mentioned the importance of a proper needle exchange, and that was something that was mentioned in the previous presentation as well, that we do have needle exchange services here in Prince Edward Island, but at a very limited capacity. Do you feel that we should be expanding those services?
I'm not 100% knowledgeable on what the capacity is in terms of the exchange program, but just having the exchange program is certainly of benefit. In a broader context, when you look at a supervised injection site, if you have a needle exchange there, then that spreads across the, basically across the spectrum that we would see. What we run into now is a lot of needle discard, where if you had that ability to do your exchange in concert with a supervised site, you may not have that, or it would certainly help to drive that down. It's certainly not going to eliminate it for sure.
Trish?
Thank you, Chair. And in the previous presentation as well, we learned about safe consumption sites, but also a slightly different model of urgent public health needs sites that is more of a short-term sort of approach that can be implemented more quickly and has had success in other places such as Halifax very recently. Is that something that you've heard about or that you think would be a good fit?
I'm not overly familiar with the situation in Halifax.
Trish?
So I guess just to unpack some of your presentation a little bit. So what role do you think some form of overdose prevention services, whether it's a safe consumption site or other form, what role do you think they should or could play here in Charlottetown?
Again, if it gets tied with what currently the current situation with the needle exchange programs, how you would set that up, where it would be. Obviously, from my comments, for those that would be opposed to such a thing, you're going to have the, where's the location, what's the impact going to be on my neighborhood, all that kind of a thing. From our perspective, we know from the work that was brought into play with respect to the introduction of the methadone program, we've seen a lot of benefit from that. In terms of what we did at one point in time was we did tie a fairly significant drug operation to the startup of the methadone clinic, so that kind of helped from an enforcement, because basically at the end of the day it's not just an enforcement mechanism, it's enforcement, it's what we can do in harm reduction, it's what we can do in helping mental health, so it's right across the board. So there's a lot of things that collectively we can do to make to bring in improvements.
Trish?
One more, I guess.
Sure.
So can you tell us a bit about what harm reduction practices the Charlottetown Police have adopted to support those who are using drugs?
We do have some, unfortunately, it was typically the not in my backyard scenario. We did brand and begin to, or attempt to launch basically some boxes, lockable boxes for safe discard. Unfortunately, when you look at where we would want to put them, there was a little bit of backlash, and we still haven't got them installed, but we're working towards that. So that's one of the things that we would like to see, is at the end of the day, if we could work around something else that we didn't have to do that, then fine. But we've recognized that that's one issue that we can help to deal with and look after. Needle discards is an easy one, basically, we think. But again, it comes into where you're going to put it, how you're going to put it, and getting community buy-in. And that's the big thing, is getting community buy-in, because at the end of the day, it's easy for people and society as a whole to criminalize the behavior, and that's the first premise where people come from. And basically, at the end of the day, like I said in my presentation, nobody wants to be a drug addict. That's, nobody starts out that way, or nobody says, I'm going to have a career change and this is what I'm going to do. It's just one of those things that people get caught up in it, and then we see the result of it. So basically, it's a lot of other social issues that, because of what they are, turn into justice issues.
Carla?
Thank you, Chair, and thank you very much for coming in today. And I appreciate that the last presentation and this presentation, you're both coming at this from completely different perspectives. So I appreciate that. And there was something that Trish had said. I'm going to kind of jump off, and I may have misunderstood something, but I hadn't heard about it before. They were talking about in the last presentation about when there is a drug seizure and the analytics run on the drugs to see what other agents might be in that particular drug. And I'm wondering, I think this question was already asked, but I don't know if it's the same. Is that something that we do on PEI?
We would, for our purposes, in terms of going to the courts, we would have an analysis done basically to determine, to make a determination as what's in the substance, basically to confirm what we believe is already there. So we will send it away, but so we will get an analysis back to indicate that if we think the product might be cocaine, that it's cocaine. It might be cut with some other kind of materials as a cutting agent, whether it be fentanyl or whatever. We actually do have some drug testing that we can use for our own purposes, but we don't use it for court. We send it away to get confirmation through a lab.
Carla?
Thank you, Chair. And is that information that you make available to the public, or if let's say you found fentanyl cut into an illicit drug, is that something that you would kind of put the red flags up to alert the public that there are indeed currently drugs on PEI that may contain fentanyl, or is that?
We would make, not necessarily related directly to the individual, but we would make a broader statement basically that we're encountering fentanyl, we're encountering methamphetamine, those kind of things. Yeah.
Carla?
Thank you, Chair. And I'm wondering if you can speak to us a little bit about, from your perspective, from police perspective, how drug use has changed over the past few years on PEI, and perhaps maybe a focus on how it's changed during the pandemic.
We're in the East Coast, we're like, we catch up, basically. So we basically see trends develop in the West and work their way east. That was true with fentanyl. That was true with methamphetamine. A lot of times it depends on the price points, whether or not, like in the case of methamphetamine, it's a pretty cheap product to make, and the price points on it are fairly high. So, that can determine usage and things of that nature. We've seen, over the course of time, we saw a huge increase in the opioid use. We actually, in one of the presentations that we have put together, and we've delivered it publicly, but is slides showing individuals that have been involved in armed robberies when the opioid crisis was basically, or the opioid situation that we were dealing with was coming to its height in 2014, 2013, 14, 15. And if you looked at the individuals that were involved, if you saw photographs of them, basically it would look like a high school graduation photo. That's the age of the people we were dealing with. Because of some of the interdiction things that we had done, coupled with the introduction of the methadone program, we've seen opioid use go down. It's not gone, but we've certainly seen it gone down to the point where when you look at what our and I don't have the data with me, but when you look at our armed robbery data from those years compared to now, it's virtually our robbery situation is, I wouldn't say non-existent, but it's certainly well below what it was.
Carol?
Thank you, Chair. I'll just ask one more question for now. I'm wondering, what role do you envision the police playing in the creation, implementation of a supervised injection site?
It would depend on where it is. I mean, we would get from our perspective, to help allay the fears in the community that just because of people, the way communities ordinarily work, they would say, that's going to raise issues. We'd heard the same thing with when the methadone program launched. There's going to be problems where the clinic's going to go. In all honesty, there's very few problems that we have associated to that. We've done things in terms of just our own presence, with our, both physically and with our E-Watch program, things like that provides an umbrella piece there that kind of gives a little more community comfort, if you will. So those are the kind of things that we can do. The biggest thing is just to try and reduce the stigma, because at the end of the day, some of these individuals get victimized as well from other addicts. So it's putting things in place where we can reduce the stigma, reduce the victimization, and things like that. And it's a learning curve for some of our people too, because our people at the end, we have laws on the books that says if you're in possession, you shouldn't be. You lay the charge, you do all that kind of thing. But there's other, it's that broader piece of nobody chooses to be in that predicament.
Trish?
Great. Oh, thank you, Chair. In the previous presentation, it was discussed the role of the federal Good Samaritan Act and how that the role it plays in protecting those who are seeking help when they are in a situation of an overdose or expected or possible overdose. Can you tell me a little bit more from a law perspective or a law enforcement perspective how that works?
Well, the Good Samaritan Act came in, I believe, in 2015, I think it was. But anyway, the Good Samaritan Act basically provides the opportunity for individuals that may be involved in using illicit substances where something goes awry. The individual can call 911, make the report. They don't have to stay. But if they do, at the end of the day, when first responders arrive, the leverage under the Good Samaritan Act basically removes the ability to charge under the Controlled Drug and Substances Act for possession. And that's basically, and therein lies the name of the act, is, it provides people the opportunity, give us the call to see if we can help the individual that's in trouble. And at the end of the day, we're not going to charge anybody for, possession of any substances that they may have on themselves that may be present, that kind of thing. If they leave, they leave, but if they're there, we wouldn't charge them. Now, the Good Samaritan Act doesn't alleviate situations that may arise where the individual is still there and we may have a warrant for their arrest. That's still in play. But we don't, in terms of the actual ability to charge or the laying of a charge on the Controlled Drug and Substances Act under Section 4 for possession, that overrules it.
Trish?
Thank you, Chair. And so what would you say to individuals who might be scared or nervous about calling for help or having the police come when they are facing a situation of an overdose or needing supports? What would you say to them to make them feel less scared to call?
Therein is the ability to leverage other basic, good pieces of legislation to help protect individuals that may get themselves into these situations. That, you don't have to have a fear that we're going to charge you with anything that may be there in terms of the drug paraphernalia or any of the substance that's left. That the Good Samaritan Act overrides that. So we wouldn't charge you. What basically at the end of the day, what we want people to do, if someone gets in trouble, call us so that we can bring the help to them.
Trish?
That's good to hear. And are there any ways that the police are currently actively, letting people know about this, or that is there any efforts to communicate this to the public so they know a little bit more about this? How it works?
There was originally when the Good Samaritan Act first rolled out, but it certainly something that could be resurrected, I guess, for lack of a better term. But when it was first rolled out, there was a lot of basic information that went out to indicate it was there. Maybe not as much play, if you will, on PEI as compared to other areas that may have had more significant issues, but it was certainly put out.
Thank you, Chair. So last summer, the Canadian Chiefs of Police called for the decriminalization of simple possession. And Chief Adam Palmer, the head of the association, was quoted as saying, "Arresting individuals for simple possession of illicit drugs has proven to be ineffective, and it does not save lives." So just wondering, do you agree with this position? And is that what you would say is true as well?
I'm a vice president on the CACP board, so yes, I do.
Great, yeah. Great. So,
Trish?
follow-up question then. So have you had any discussions with the Department of Justice and Public Safety about advancing decriminalization?
From a board perspective, I can say that there has been some discussions at the preliminary stage. Basically, not directly with the board, but with the board president and others with the federal government. So that has been discussed. There was basically a meeting held just a few months ago. There was about 8 to 10 points that were discussed, and that was one of them. Yeah.
Trish?
Would you see that this role, this committee might also have a role in advocating for decriminalization? Is that something a recommendation you think you would like to see this committee put forward as well?
Collectively, to have that discussion would go across all levels of government, is my personal opinion.
Trish?
That's it for now, Chair.
Perfect. Great. I just have a couple questions. How many calls does your department or do the police receive a year regarding drug overdoses?
I don't have that data right at my fingertips, but I can tell you in terms of where we've had overdose related situations where we've actually had to go to either assist EMS or ourselves in terms of naloxone administration. Mm-hmm. They have gone up this year versus any other year. We were probably in the first year that we had naloxone, which would be about 4 years ago. We hadn't used it. Our service hadn't done any administration of naloxone for about 1.5 years, 2 years. But we've seen it slowly start to creep up.
So, yeah. And so all officers carry naloxone on them?
Yep.
So with was your department consulted by the city of Charlottetown when determining to fill in the tunnels underneath Water Street?
We had a conversation with Public Works about that, yeah.
Okay, prior to. So what advice did you give them? Was it
Well, basically we brought to to their attention, and they had some awareness that there was an issue there, but we had brought to their attention, here's an issue. We had some other issues prior to that with, and it wasn't closing anything or anything by that nature, but where there was a transient population that during the summertime would be in different places in the city, underneath the bridge approach. So it was just basically, you know, it's like you would try and address one area and then it migrates to another spot, and that seems to be where it went. And so when we realized, I mean, that wouldn't be a short period of time that particular area was being used. That, you know, the collection of all that was there over a period of time.
Yeah, exactly. And what are you seeing from the people that were displaced that are still using? We just heard from the other guests that they've maybe moved all over the place. How has that been since that closure?
Some of it's difficult to to really put a gauge on, particularly this year with the pandemic situation,
Yeah.
because we get a lot in the summertime, a lot of transient population, and that was the case when people were you know, initially, like I mentioned at the bridge, that would be a summer transient population that were there. Mm-hmm. So we didn't have that influx of transient youth and others coming into the city this year. Mm-hmm. But we've certainly, you know, you see some displacement. We see more, you know, we're probably seeing more calls for needle discard than we have in the past.
Okay, so yeah, that absolutely is. A few years ago, the police force did a raid in Charlottetown. It was a big, massive raid where you went and I think you went to places, and it was one night. It was very successful. Does raids like that help? You know, did it help in the future? After that, did you notice a difference in consumption?
That's what we had called Operation Clean Sweep.
Yeah.
And that was the enforcement effort that was put together and tied roughly to the timing was roughly to the start of the methadone clinic. So we did see, you know, we were able to not totally choke off, but we were able to choke off a good portion of the supply, which drove people to the methadone program, and so that helped. And so we saw that's where we saw the benefits of our armed robberies going down, our, you know, thefts from vehicles going down, our theft from vehicles now are going up. And again, that can come to basically price point, whatever substance you're using. Is it, you know, for the sake of a couple loose change that's in a car can look after you for, you know, for a day or so. You know.
Perfect, great. Trish?
Thank you, Chair. Thank you. And so just to go back just briefly to the decision to close the culvert, do you feel that the process was sufficient in how that all ended up playing out, or would you do something differently next time?
Well, to do that certainly basically paid dividends to a certain extent in terms of, you know, what kind of risk were people getting into going in there, staying in there, that kind of thing. The other, you know, the needle discards that were in there, that kind of thing. Basically, at the end of the day, though, what you're doing is you're closing that down, but you're displacing it to someplace else. Those are the things you have to keep in mind. It's like, you know, when we do any kind of enforcement action where we may step things up in terms of property crime, it may work well for us here, but we may just, you know, at the end of the day, we might displace the problem in Stratford. You know?
Trish?
And just so I understand the process of how that decision came about to close the culvert in the way it was closed. So, you know, who is the decision maker in making that happen, and who was involved in making that decision, I guess?
We brought that to the attention of Public Works. Okay. At the end of the day, that's a Public Works issue. They could either grade it, close it, leave it open.
Trish?
Okay, so we'd have to check in with Public Works to see if there was any further consultation at all on the impacts, as you say, of, you know, what happens when you close that off, and then that's, okay.
Municipal, yeah.
So I'm also wondering about the mobile mental health crisis teams. So we talked a little bit about that in the previous presentation. We've talked about it in several presentations in this committee. About there's different models and recommendations around whether or not police should be involved in those teams. Can you tell us a little bit about, from your perspective, how that's developing and what that will look like for police involvement?
We're still working with those in mental health. The discussions are still going forward on terms of how they want to put and roll that out. Basically at the end of the day, we could say, look, that the mobile mental health crisis unit doesn't necessarily need a police officer. That's a discussion that at the end of the day, it likely is a better fit if there is, because you can't say at the end of the day mental health calls are not going to involve the police, because you're going to have a certain number of mental health calls that are, just given the nature of what may take place, police are going to have to be involved in it. So if we have the right mix of training and staffing, that would give us a better response, and for collectively for everybody have better outcomes.
Trish?
That's all for now.
Is the committee okay? Great. Just want to thank you for coming in, Paul. You did a great job, and thank you for your time. And what we'll do is we'll take a short recess, and we'll come back with the rest of our agenda. Thank you. Okay, we're back. We're moving on to number 4, the discussion of scheduling. Dr. David Hodgkins from the University of Calgary has agreed to appear via Zoom on Friday, February 5th at 1:30. So, regarding gambling. Since our meeting last week, there have been a few different names suggested through correspondence with the clerk to speak to the topic of gambling and addictions. So, suggesting if the community would like to hear more on the topic, we can send letters to Health PEI, the CPHO department. Maybe I'll let the clerk just kind of talk about that for a little bit.
So just in my correspondence, there's just been some back and forth on possible suggestions. I know we had previously agreed to send an invitation to Nora McCarthy. It's a preference that either more presenters be involved that day to add to the conversation. And I think the chair and I had previously discussed that if the committee would like to maybe start from the top down and send letters to either the department or CPHO and have them designate who they think would best come in to speak to the topic instead of kind of going off suggestions from word of mouth. But it's up to the committee.
Yeah, we're in a little bit of a time crunch.
Yeah.
So.
Well, it is since we are having the meeting on February 5th, that kind of starts the discussion. It might be a good idea to use this as a jumping off point after the House sits.
just open up to the committee. So do we send the letter to Health PEI or the CPHO? I know Dr. David Sabathia is talked about this issue before. So,
This is on gambling
yeah,
addiction?
yeah. To fill up. So we might do that. We might send him a letter directly and see if he would, Trish?
In that letter, can we also, ask that he speak on what advice CPHO has given to Cabinet about gambling addiction and what their recommendations are for online gambling? I don't know if we can ask that or not, but I'd like to know what their perspective is on that and what their advice is for online gambling.
The committee can certainly ask whether they provide it or not, but if that's an agreement of the committee, I can certainly invite them and ask for that information. Is it just that letter we'd like to send on this topic? Or is there anyone else?
So we'll do that, and then maybe to Health PEI too.
That's two, correct?
Mm-hmm.
And we're short on time, so let's get those two in and we'll go from there, wouldn't we?
Okay. Perfect.
I was just clarifying that the whole committee is in agreement on those.
Mm-hmm.
Okay.
Perfect. So that's going to be, we'll work on that, and we'll keep you updated, obviously, through email for the committee members. And then, so number 5, just moving on to any new business at this time. Heath?
Wonder if it might be time again to bring someone in from mental health. Just, the puck's never reopened, and we've got the mobile mental health clinics supposedly getting ready to go. It might be, wouldn't hurt to have an update on, I don't exactly know who, if it's Dr. Heather Kaiser or somebody relevant to that. Bring them in and just give us an update on what's happening,
Yeah.
and especially Unit 9 again, and that kind of stuff.
Okay. Yeah, it's a good suggestion. Trish?
Yeah, I thought, didn't we prioritize the mobile mental health units? I thought we did prioritize that, and then we could just, perhaps send a letter to that. Do we have a meeting set up? Next week.
Yeah.
Would it be possible for the committee to send a letter asking for for them to speak about what he's mentioned, so Unit 9, and we can get a more robust conversation about mental health?
Perfect. And we'll ask to see if Dr. Kaiser can come in to that meeting.
And the closure of the puck, of course, at Hillsborough Hospital, absolutely critical that we get more information on that, so, yeah.
Okay, perfect.
Just to clarify, would that be getting the current presenters, Dr. Heather Morrison and Aaron Bentley, to speak on this, or asking Dr. Heather Kaiser to come in after to brief the committee?
Maybe we'll do 2 different ones.
Okay.
So we'll send it out to get Dr. Kaiser in after.
Okay.
So, Trish?
Although I believe Dr. Heather Kaiser is on leave right now, so it would have to be whoever is in that position, I believe, unless that's changed, but that's, anyway, you have to find out.
I think we'll send the appropriate person. Okay. Perfect.
Just ask, and then it'll be up to you,
Okay. Perfect. So we'll send that off, and okay. Any other new business? Michelle?
I have a couple of items. I have motions. I don't know if I can present the motion, but I can just summarize. I think, anyway, so the first one would be to request that the standing committee look at the Freedom of Information and Protection of Privacy requests and that process. So proposing that the Access and Privacy Services Office be asked to come in, as well as the Information and Privacy Commissioner, to discuss issues that might be existing in the timelines, or that those two departments might be experiencing. I can read the motion into the record if you want, if that's necessary, or...
Yeah, well, let's hear the motion, and then we can debate the motion.
Okay. So I move that the Standing Committee on Health and Social Development invite the Access and Privacy Services Office to discuss office resourcing, the processing and completion of information requests, including increasing requests for time extensions and an increase in deemed refusals, the impact of the COVID-19 pandemic on access to information requests, and any other matters the committee or APSO considers appropriate, as well as the Information and Privacy Commissioner to receive an update on the work of their office, learn about challenges and areas of opportunity with respect to the freedom of information and protection of privacy, discuss the impact of the COVID-19 pandemic on their office, and any other matters the committee or the commissioner consider appropriate.
Okay, that motion's on the floor, and I don't know, I'm just asking as the chair, I don't know if does it fall under this committee? Yeah?
It does, so FOIP requests would fall under Justice and Public Safety,
Okay,
which
that's
falls
what I
under
was
this
looking
one.
at. Perfect, okay. Perfect, thanks for the clarification.
Yeah, perfect.
Trish?
So, thank you, Chair. So I'm not sure, I believe that the honorable member can't move as she's not a member of the committee, but I so moved the motion as read in her.
Okay. Okay, so that motion is being brought forward by Trish, correct?
Yes.
All right, perfect.
And I believe there's paper copies too, if members.
Oh, perfect, yeah, okay. Excellent. Open for discussion, we can debate the motion. Oh, sure, yeah. Oh, yeah, thanks. Does everybody, will just maybe start with number, if you want to discuss number 1 or 2, or we can break them down, or if you have any sections that you would like to discuss in that motion? This time.
I'm fine with it, Chair. A lot of it we discussed at the e-gaming committee, but
Okay.
I'm fine with it.
Perfect. Okay, any other feedback with that?
Is there a reason why this is coming up now and not when we had our work plan? I'm kind of curious.
That's it.
Chair,
Yeah,
Speak to that?
Michelle.
And it's a good question. I mean, it is something that's come up because of recent activity and some feedback that FOIP requests are taking longer than what would be in the legislation. And so I think it would be responsible for us to look into that, to see what the APSO office is experiencing, and are the public bodies meeting the timelines that are set out in the legislation, and as well, is there, resourcing issues in order for delays, because there has been reports that they're taking longer than what the requester would expect.
Okay. So, yeah, so, I guess the second part of your question is our work plan is pretty full and kind of overflowing till the end of February, and I would just ask the committee if this would be something that how we would prioritize it. I guess how we'd prioritize this motion. Yeah.
Is there another Friday we can add? I know that we did that for another topic. I mean, it is just a short amount of time before the next sitting, so we kind of have to do what we can to make it work.
Okay. We'll just we'll ask the clerk, and then we'll get you to respond to that.
I believe the schedule is either full of scheduled meetings or holds that other committees has leading up to the legislative planning week.
Corey?
I guess that kind of answers the question anyways, but I was going to say, perhaps after the legislature closes.
Yeah.
It's just like with ministers, like, you can't just schedule a meeting that quickly and off. Like, they can barely make the ones that.
Okay. Michelle?
I'd just like to point out that if there is a resourcing issue, there's an upcoming operational budget, and if there is any concerns within the department when it comes to resourcing, that we would be able to address that prior to an operational budget being tabled.
Okay. Corey?
And I think that's fair, but I don't think we need to try and squeeze it in before the House sits. If we have other stuff on the work plan, they can make a presentation to the Department of Finance in their budget consultations.
Yeah, perfect, yeah. Okay, so is that okay to vote on the motion? We're gonna vote on the motion, then we'll discuss next steps. So all in favor say aye.
Aye.
Those against say nay. Perfect, this motion passes. So what we'll do is is it okay if we send a letter to, would you like to send a letter to?
I think we have to, we just pass the motion.
I know, but, and then I would say, we don't have any time before the ledge sits to get them in to prioritize this immediately after the session. I don't know if committees, this is a question with the break weeks in between no, the committees aren't sitting? Trish?
It's an interesting question because as we just found out yesterday, the opening of the legislature will be delayed 2 days from what was originally expected.
Yeah.
So perhaps it is worth a discussion of whether or not we would open up the possibility for a meeting the Wednesday before the week the sitting starts, since it's starting on a Thursday now instead of on the Tuesday.
So that'd be the 24th of February?
Right.
Yeah.
No, the 17th of February,
Oh, okay, yes.
because the 25th is when the legislature opens, so that would still be like a full week before it opens.
Yeah.
I mean, it's.
Yeah, is the
open for
17th,
discussion, I
the
guess.
17th open?
It is open. It's up to the committee how they'd like to proceed.
Yeah. How does the committee feel about that?
I think it's an important topic, so I would certainly support that.
Okay. So we have one support, all in favor of that?
I'm
Corey?
fine with it, but you'll just have to see if they're available to come that day.
Sure, yeah, absolutely, yeah. So we'll send them a letter inviting them in for the 17th of February if they can do it, and we will wait to hear correspondence. Okay, great. Michelle, did you have anything else?
I have another
Oh, okay, yeah,
that I'd like to
Perfect.
put forward.
yeah.
And I do have copies of this as well. So this is a motion on the IRAC report for the Brendel land sale. Thank you. Whereas the Legislative Assembly has a role in scrutinizing and overseeing the actions of government, and whereas the Legislative Assembly and its committees and members hold and enjoy the same privileges, immunities, and powers that are held, enjoyed, and exercised by the House of Commons of Canada and its committees and members, including parliamentary privilege. And whereas in 1991, the Standing Committee on Privileges and Elections of the House of Commons studied whether a standing committee had the power to compel the production of a report which contained personal information protected under the Federal Privacy Act. And whereas the Federal Standing Committee noted the power to compel papers and things was central to the ability of parliamentary committees to discharge their responsibilities, and found that the Solicitor General was not prohibited by the Privacy Act from providing complete reports to the Standing Committee on Justice and the Solicitor General. And whereas the Standing Committee on Health and Social Development enjoys jurisdiction over matters of justice and public safety, which include law enforcement and the access to information and privacy, protection of privacy regime, therefore be it resolved that the Standing Committee on Health and Social Development requests the attendance of the Minister of Justice and Public Safety and any other witnesses he deems necessary, as well as the production of an unredacted copy of the IRAC investigation of the Brendel land sale for the committee's consideration in a closed session. Therefore, be further resolved that if the Minister of Justice and Public Safety refuses to appear and produce an unredacted copy of the report within 2 weeks of the request, the Standing Committee on Health and Social Development shall issue a subpoena to the Minister of Justice and Public Safety for his attendance and for the production of the unredacted report.
Same thing.
Yes. So as last time, will move as read, that motion.
Perfect. Okay. So that motion's on the floor. So looking to open up debate on that motion.
Just a note, I believe it's not within the powers of the committee to subpoena a minister, is my only note on that.
Okay, thank you, Clerk. Heath?
Something that I was actually circled here on to actually subpoena somebody is, I don't know if that wording is correct.
Chair, I would be happy to rephrase that to,
It's on there? Sure. So, are you suggesting we're gonna amend this motion right now?
well, if,
I can make an amendment to remove the word subpoena and put in ask, I guess, or.
Insist.
Because really subpoena, you're looking at if they don't show up, then there's penalties. And I don't think the committee has the power to provide penalties or fines, or whatever.
Okay. So, we're gonna take out that, we're gonna put in insist. Is everybody okay with that's the suggestion on the floor? I guess Heath's making the amendment, so,
I just had a question whether isn't really what we want, or what the committee want, this is a report more than the minutes. I'm just asking the question.
that would be to the mover.
I'm asking.
Michelle can answer it. just-
Michelle?
I think it's important that we actually hear from the minister, because I think that there's been a lot of back and forth on this, and there's it's an opportunity to clarify just, what the progression has been. So I
Okay.
think it's important to have the minister appear.
All right. Great. Trish?
So did we passed Heath's amendment?
We haven't voted on that
Okay.
yet, so,
I'll hold what I want to say until.
okay, so, we'll vote on the amendment to, put in the word insist. All in favor, say aye. Aye. Okay, that's there.
Remove subpoena, the word subpoena, and then include the word insist.
Yeah. Can the clerk read the sentence again? Or, so what, the last sentence?
Yeah, so it would be,
From the Standing Committee on Health.
and the Standing Committee on Health and Social Development shall insist the Minister of Justice and Public Safety attend and produce an unredacted report.
Is that okay? Great. Corey?
Sorry, Michelle, maybe isn't my committee trying to get the minister? I think have we asked the minister to appear on this? We've asked him to appear on a few things, but.
Yes, there was a request to appear, and he wrote back in correspondence saying that he couldn't at this time, essentially.
And there was reasons why. Such as, I think the third party has started litigation or something, I believe.
Yeah, there's ongoing litigations, like you said, that prevent him from appearing.
Yeah, and I mean,
I guess I don't quite see what we're trying to accomplish here, but.
but this is where a request like this would be made. And so I guess that's why we're having this discussion. Because justice does fall under here, so yours is natural resources, so, I mean.
Yes, but I guess what I'm saying is that our committee asked the minister to appear to speak to the report, I think, is that, I'm not quite sure what the wording was, but, and the minister wrote back with what I thought seemed like legitimate reasons of why he didn't want to appear at this time. And now we're gonna try and go through this committee, and at one point, we're gonna try to subpoena the minister. And I don't know,
Yeah.
I'm pretty fair, I'm not, but this is grandstanding on the issue, and I don't.
Yeah. This committee is
voting
independent,
against
this committee is independent, all the committees are independent, so we operate based on motions and the abilities, so, or what's brought forward to us, so I don't see a problem with this motion. I mean, I could review your
It's a motion,
correspondence.
we get to vote on it, I don't have an
Yeah.
issue with that, but
Yeah, perfect,
I'm
yeah,
just stating my opinion on it,
Sure.
which I'm
Absolutely.
entitled to do.
perfect. Thanks, Cor. Trish?
Thank you, Chair. So just since we've changed the wording and removed subpoena for the reasons discussed in terms of subpoena to subpoena the minister, can we subpoena the report if it's not readily provided?
I think, does subpoena
See,
have to do with humans? Like, or can?
I don't think so.
No?
Sorry, the committee does have the powers to request any document, so they don't necessarily have to go through like a FOIA process. You can just request the report.
And that's sufficient? Then we can't be told no if we make that request. There's no need to have any stronger language. Okay, great. Just checking.
So, perfect, good questions. Anybody else, would anybody else like to speak to this motion?
So,
Corey?
is that what's being asked for in the motion, is to subpoena the report? Is that? No.
Being asked to produce an unredacted report. So the committee is asking, sorry, Chair.
Yep, go ahead, Michelle, I'm just reading it, go ahead.
The motion is requesting that the unredacted report be provided to the committee, which is within the rights of a standing committee to ask that a report be produced.
Yeah, so that would be the first therefore be resolved, and the second one would be to insist the minister come in. That's as the motion stands now. So if there's no other further dialogue, I'll ask for a vote. Corey?
I guess, I'm assuming what's gonna happen is if you write the minister, he's gonna send back exactly what he sent the other committee, which we were trying to do this through. What's gonna happen then?
Michelle?
I've provided precedents of where it has actually been ruled in the House of Commons and where our rules are silent and the House of Commons rules prevails. And so we've provided a precedence where it has actually been reviewed and been that they couldn't produce it because of other reasons as not being a valid reason not to produce it, because the legislative committee has the ability to request and have a report produced. I'm happy to provide the ruling from the House of Commons as well, but there is precedence there.
Corey?
I guess my comment was more to, if the minister writes to the committee and says that, I'm not necessarily a report, but says for the reasons he can't come in, which I'm assuming will be the exact same reasons, he didn't want to come into the committee I chair. And on the report, I appreciate the member said that she's provided precedent, and perhaps that's correct. I don't know. But is the clerk able to do research into this, and then come back to them? Can we do this, or is that perhaps we can?
From my understanding, it is that the committee can request any document that they wish. And I think that she would be correct in saying that at least, yes, yes, any documents or materials, the committee has the power to, yeah.
Anything else? Yeah? No? So, all those in favor of this motion, say aye.
Aye.
There's two. All those against, say nay. So,
She's just
It's two.
just to clarify. She's the sub, so.
okay. All right, so we'll try that again. I'll call the question. Okay, so the motion reads, whereas the legislative assembly has a role in scrutiny, just that part? You want me to do the whole thing?
Just the part that the clerk clarified there at the end.
Oh, okay.
Yeah, sure. Sorry, I have a photo of it because we didn't have enough copies. The Standing Committee on Health and Social Development shall insist that the Minister of Minister of Justice and Public Safety attend and produce an unredacted report.
Great. So that was the amendment. So the clerk just read the amendment, and that passed. And so now we'll just call for the question. So all those in favor say aye.
Aye.
Three, and all those in favor say nay. So that passes 3-2, so a letter will be sent to Minister's office. So, perfect. Any more new business? No, perfect. Okay, so I'll ask for a motion to adjourn. Carla? Okay. This meeting is adjourned.